Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We're going to cover drugs 36 through 40 of the top 200 drugs today. Before we do that, go check out the top 200 study guide at reallifepharmacology.com. It's a 31-page PDF, absolute no-brainer. For you to have simply an email will get you access to that. We'll also get you updates when we've got new podcast episodes available as well as other content. So again, go check that out, reallifepharmacology.com, top 200 31-page PDF study guide. All right, so number 36 is Lorazepam. Brand name of this medication is Ativan. This is classified as a benzodiazepine, kind of a broader class. I guess you could consider it an anxiolytic. Primary use is, as you could expect, use short-term for anxiety, ideally short-term. I've definitely seen patients on it chronically. Other indications, alcohol withdrawal, seizures potentially. You do see it in hospice patients a fair amount for, agitation and anxiety. Rarer conditions, you may see it utilized for serotonin syndrome and neuroleptic malignant syndrome. Those are kind of two drug-induced states where we could have some increase in anxiety and agitation there as well. So those are some of the common uses or some of the situations where you may see this medication utilized. One nice thing with Lorazepam, maybe compared to some of the other benzodiazepines, is it does have a ton of different dosage forms. So we've got tablet formulations, we've got oral liquid formulations, we've got injectable formulations. So that can certainly be advantageous depending upon what we're trying to do with that medication. Adverse drug reactions. So if you remember alcohol in a pill, that's the easiest way to remember the majority of adverse effects with Lorazepam. So it is a depressant type medication, so it's going to cause some sedation. It can increase the risk for confusion. This is more problematic in our elderly patient population. It can increase falls risk, which is obviously a challenge in our older patient population as well. Slurred speech, another example of an adverse effect that you may see as doses escalate with Lorazepam. As far as drug interactions go, probably the biggest thing is other sedative type medications on top of using Lorazepam. So I think of first generation antihistamines, trazodone, older skeletal muscle relaxant, gabapentin, pregabalin. Other medications, and one that has a boxed warning as far as drug interactions go, is with opioids. It can increase the risk for respiratory depression, so that's definitely something to monitor for closely if you've got somebody on Lorazepam in combination with an opioid medication. Last thing I wanted to mention, maybe a couple things here. It is a controlled substance. So it's a Schedule 4 controlled substance, so there is the risk of addiction and dependence, which is why we try to minimize its use to short term if possible. And I also wanted to mention there were some new draft guidelines out, 2024 draft guidelines on benzodiazepine tapering. And I did post about that at MedEd 101. So if you Google search MedEd 101 2024 benzodiazepine tapering, you'll see kind of those draft guidelines and information on that if you're looking for more details there. All right, moving on, the next medication, number 37, is Phenazopyridine, and brand name of this medication is Pyridium. This medication is a urinary analgesic. It helps with painful urination. Most commonly, I've seen it used in conjunction for a couple of days, particularly in patients who've maybe been diagnosed with a UTI and they've got significant painful urination. You may see Phenazopyridine kind of added on top of an antibiotic. Now, I will caution you, be careful with patients out in the community. So if you're in a community pharmacy, for example, or if somebody's asking you for ambulatory care type recommendations saying, hey, I've got some painful urination. Is there a medication used to treat this? You want to make sure that those patients have been assessed, whether it be for a urinary tract infection or some other medical urological condition. You definitely want to get those patients assessed because painful urination definitely isn't an incredibly common thing for most patients. So usually there's something else going on with it. So again, if you see somebody, trying to buy this medication, get this medication, you definitely might want to inquire a little bit, ask a few questions, and make sure they've been assessed and get a kind of a background on their symptoms and what's been going on, just to see if we need to dig a little bit further into that diagnosis and have them tested and assessed for other things. So, important thing, patient education thing to remember there with phenazopyridine. Adverse effect profile. One unique thing with this medication is it can change urine color, and that color is a red or orange type color. That is definitely probably one of the more common unique adverse effects. Typically, it doesn't result in anything, but obviously it can be pretty unnerving to the patient if they see that. Other adverse drug reactions usually are pretty rare. You may see, on rare occasions, skin reaction or maybe some GI upset. Kidney function is important to take a peek at. If you've got a patient whose creatinine clearance is less than 50 mils per minute, it's recommended to avoid phenazopyridine. There's rare situations, case reports associated with acute kidney injury, certain types of anemia, methemoglobinemia. So definitely some potential issues there in using phenazopyridine if patients have poor renal function. All right, moving on. The next drug we've got is hydroxychloroquine. Brand name of this medication is Plaquenil. This was definitely a hot topic for debate as far as whether it was effective for COVID or not several years ago when the whole COVID thing was in full swing. But it's a medication that's primarily used for rheumatological disorders. It is classified as a DMARD, so that's a disease-modifying anti-rheumatic drug. It is also classified as an anti-malarial drug. It has some anti-malarial activity. Primary use I see in practice on a chronic basis. You've got rheumatoid arthritis, and then lupus is probably the other one that I see it utilized most often. All right, adverse drug reactions with hydroxychloroquine. So one of the ones that's probably the most highly tested on, and definitely one that I've seen come up in practice quite a bit, is hydroxychloroquine can cause some eye toxicity, more specifically retinopathy. And this is a concentration-dependent adverse effect, so obviously higher the dose, more frequently we're giving it, the more likely this eye adverse effect is going to occur. So definitely making sure that patients are having routine eye exams and monitoring their eyes, and definitely should report any issues if they start to experience some unique changes in their vision, for example. There are some other rare things associated with hydroxychloroquine, hemolytic anemia, particularly in patients with G6PD deficiency. Hypersensitivity reactions have been reported. QTc prolongation has been reported as well. So again, kind of some unique things with hydroxychloroquine. There's a bigger list as well. But again, probably the most important thing if you're taking an exam, and a really unique thing, is that risk for retinopathy and eye toxicity. All right, next medication is Lidocaine, and we are specifically focusing on the topical patch. So that would be Lidoderm would be the brand name there. This is a local anesthetic. So the patch is essentially supposed to be placed on the location where the pain is. Most common type of pain that lidocaine patch is going to be beneficial for is neuropathic type pain and postherpetic neuralgia. Those are probably the two most common situations that I see that lidocaine patch used for. An important thing to remember with the administration of those patches. So first and foremost, they act locally, but you can get absorption over time into the systemic circulation. So an important patient education point is to remind patients that it should be kept on no longer than 12 hours. And that's really to try to reduce that accumulation. Now, when we compare a lidocaine patch compared to a fentanyl patch, for example, fentanyl patches actually have systemic absorption and have systemic and central nervous system type effects. Fentanyl is an opioid, of course, there. So that's definitely different. A fentanyl patch is not meant to be used in a local area and placed on a local location. If your pain is on your elbow, you aren't supposed to put a fentanyl patch on your elbow. That's not the way it works. It requires systemic absorption and getting adequate concentrations into the bloodstream. Versus lidocaine patch, that's definitely more of a localized type effect. So if you've got low back pain, that type of thing, you'll see that lidocaine patch placed on the site of action. So good little differentiator there with that lidocaine patch. Now, I mentioned the 12 hours on maximum in a 24-hour period. When and if lidocaine accumulates in the bloodstream, there is risk for cardiac effects and changing the way the heart works and can cause arrhythmias and things of that nature. And I think if you've got any experience with acute care or emergency room care, that type of thing, you'll know that we use or can use lidocaine in the ACLS algorithm as medication used to treat certain types of arrhythmias. So that's the deal. That's the issue with accumulation of lidocaine. So good one to remember there potentially. All right, and our last medication of the day, number 40, is going to be Diclofenac. Brand name of this medication is Cataflam. I'm focusing more so here on the oral formulation of this medication. It is an NSAID. That's a non-steroidal anti-inflammatory drug. Obviously good at reducing pain and inflammation, but we've got plenty of adverse drug reactions with NSAIDs in general. This is worsened as we get older. Some of those adverse effects can occur at a higher frequency or be more severe. So first one I want to mention, of course, with NSAIDs is GI bleed. So it can increase the risk for GI bleed, GI ulceration, and that is definitely a big issue with NSAIDs in general there. There is a boxed warning for GI bleed as well, so I did want to mention that as well. Edema, swelling can happen, so an increased risk for heart failure exacerbations, for example. The medication can cause some potential sodium and fluid retention, so that can be a problematic thing. Renal impairment, the way NSAIDs work on the kidney, they can potentially kind of impair the function of the kidney and increase the risk for acute renal failure. This is typically exacerbated in patients who are older, obviously at risk for renal impairment, and on other medications that may increase that risk for renal impairment. I think of diuretics, for example, can increase that risk. ACE inhibitors and ARBs can increase that risk, as well as IV medications like aminoglycosides, gentamicin, tobramycin. They can increase the risk for renal problems as well. And then last, I did want to mention there is warnings on cardiovascular risks with NSAIDs, and Diclofenac, being an NSAID, falls certainly in that category. So that boxed warning is for an increased risk of thrombotic events. And then lastly, finishing up on drug interactions. So we've got to think about medications that can increase the risk for GI bleed. So corticosteroids, they can kind of have an additive effect. So if we take prednisone, with diclofenac, that can increase the risk for GI bleed. And then, of course, any medications that thin the blood. So any type of anticoagulant medication, apixaban, warfarin, for example, any type of antiplatelet medication, clopidogrel, prasugrel, aspirin. These are all medications that are going to increase that risk of GI bleed when used in combination with diclofenac. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, support the sponsor, meded101.com/store. We've got resources for pharmacists, pharmacy students, BCPS, NAPLEX, ambulatory care exam, geriatric exam, BCM, TMS. Go check out all those resources. Your support there goes directly to help keep this podcast free and available for all to benefit from. So I greatly appreciate that. If you're a nurse practitioner, anyone else in healthcare needing pharmacology education, at meded101.com/store. We've got Amazon books. We've got other educational materials. Go check out all the links there. There's going to be something there for you for sure if you're trying to learn more about pharmacology and medication management. So again, all those links, meded101.com/store. If you enjoyed this podcast, please do me a huge favor. Leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. And of course, share us, friends, colleagues, classmates, listservs, wherever people are talking about pharmacology, learning about pharmacology. Please feel free to share the podcast. I really, really enjoy seeing the numbers and educating thousands and now millions of people about pharmacology. So I greatly appreciate this opportunity and you all sharing this podcast with your friends and colleagues. If you want to track me down, suggestions, comments, didn't like what I said about something, feel free to shoot me an email, mededucation101@gmail.com, or you can connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening. Take care, and I hope you have a great rest of your day.